Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. I got Mark and Drew with me here today, and we're going to be talking over some lumbar spine pain, specifically exercise therapy versus manual. But first, let's start off with a lovely icebreaker question. So, question for the day: how do you like your steak cooked? Mark, how about you?
I'll start off by saying that I'll eat anything from basically like medium rare to like medium well, but my ideal is like medium to potentially a little bit more towards the medium rare side.
So depending on the day, but you can't go to a nice steak restaurant and then come out with all gray, right? I mean, that's just not going to work.
Order it like that, and I will say something about it, but like if they don't take it back, I'm still going to eat it.
I don't know if I'm going to pay for it though. Yeah. All right, Drew, how about you?
They were going to give me two.
I'm definitely on the rare to medium rare. Just toast the outside and give it to me nice and pinkish red. If it's a restaurant, I usually order rare because they tend to overdo it.
Yeah, I can't tell you the last time I've ordered a steak at a restaurant. It just feels like I can make it better at home. But
absolutely.
To be fair. All right, well, good stuff. I appreciate your taste as a whole. Mark, a little suspect as usual, but that's
if it goes more than medium, you've got to put like A1 or something on it. It's already an abomination.
Back to middle school now. Yeah, okay. Hopefully it didn't offend anybody there. All right, so digging into lumbar spine, as I said, really kind of looking at the exercise versus manual therapy picture here. Heard the debates, heard the arguments over the years. Spoiler alert, it's going to be both. If you listen to us long enough, if you worked with us, you know that it's going to veer into both. So we're going to save some time on that. What I'm really interested in getting you guys' viewpoint of here is obviously when you see a lumbar spine patient's got low back pain. It can be radicular, it can be radiating. There can be a lot of components to it. But what are some kind of cases or presentations that are come into your office that are going to drive you one way or the other when you're looking initially to try and figure out, am I getting more of a manual approach here versus an exercise approach at the start? So that said, Mark, give us a little feedback on what you think.
I'll start with the easy one and get that one kind of out of the way. If somebody comes in with like the classification of like low back pain with mobility deficits, like more often than not, I'm going to need to do something to help with those mobility deficits, whether that be, if you look at manual therapy, is it just facilitating? Is it just impacting the nervous system? Sure, whatever. But they need a little bit of something there before I give them the exercises to help supplement it. That one I think is pretty straightforward and most of us can probably agree on. It's the other ones, the other cases that it's like, should we do manual or not? I see a lot of folks with kind of that motor control, motor coordination classification. And so the question is like, should I manipulate them and reset their nervous system or just go right into coordination activation? And it's going to be dependent on the human in front of me. So what are their belief systems? How is their coordination activation just at baseline? Do they need my hands to help facilitate what I need to get from them? Those are kind of the couple things that I'm looking at to see if that's something that I need to go to. The nice thing about a manipulation is that it is quick, so that even if I just went with it, like I'd still have time to do the other stuff.
Yeah, good stuff. Drew?
I stole my thunder. So, yeah, like you said, the easy one is definitely when they fit that manipulation category. I tend to think of it with the manipulation primarily somebody who has pain with the movement or manual therapy, either one, whether it be mobilization or manipulation. And my primary goal is to address pain. And it's not something that I think could be centralized with repeated movements. If that's the case, and again, they have their beliefs are that, it's either going to help or they're not against it, I'm probably going to do some sort of a manipulation and then follow up with the exercise. In fact, I think the bigger or most important thing in those situations are, what are you following it up with? So is it truly a mobility thing or is it truly a stability thing? And that's where it's going to look the most different. So if they're having pain either through movement and there's maybe a catch, if it's a mobility or a low back pain with motor control deficits, I'll do it, retest it. If they have pain-free range or they don't have that catch or aberrant movement now, then I'm going to start retraining through whatever that is, versus somebody who has maybe pain at an end range, they're limited, do a manipulation, pain's less, but they still have some mobility deficits, and I'm going to be focusing on some sort of a mobility type treatment. So that's how I'm typically using it. And then if they have some sort of radiating pain and they have a directional preference, I'll often go to that first before I maybe do a manipulation, just for self-efficacy, for something that they can do at home that's a little bit easier. So if you're looking for something that would indicate, hey, this might not be my first one, and maybe a secondary treatment, some sort of a directional preference would maybe be my first one so that they can manage it better on their own.
I'll put a scenario that may break that in a very specific situation. The folks that have a lateral shift, particularly ones that are like kind of irritated, doing the manual shift correction, I find is very calming to the nervous system for them and very effective at reducing symptoms prior to just putting them on the wall and having them shift correct against the wall. And so that's probably the only time when it's a directional preference that I'm gonna like actually do more manual before doing the.
In that scenario, are you looking like the manual, you're correcting them versus like a specific mobilization or manipulation?
No, it's me correcting them.
Yeah,
and
okay.
so it's still a directional preference, but it's manually facilitated. Okay. And just that contact, that feeling of security that they get when you're there, like actually mobbing them into that, I find more effective usually early on than just putting them up against the wall and doing their self-correction.
Yeah, I would agree with that, for sure.
I like that thought. Two things I want to point to. One, Mark, I really appreciate the idea behind, there's a big difference between, hey, go try this correction in the door frame or up against the wall, and even just the simple component. We know that when we as providers put our hands on our patients, buy-in increases, belief increases, outcomes increase. And so even just, hey, do I absolutely have to correct? And maybe you do, but even just the benefit of being able to put your hands on the patient, there's going to be some perceived value there. And I think that can really tie in both things to some degree there, which is helpful. I want to point back as well to one of the things you mentioned, Drew, when you were giving your answer around beliefs and just the fact that when you hear kind of their belief around what they think is going to potentially make them better, we know that can be across the spectrum of healthcare or across all diagnosis in general. But do you guys see that to really factor in when you're treating low back pain even more so than some of the other things?
Yes, that's the one that I see the most frequently is like, I pop my back and it feels better. And the really difficult thing about that scenario is, do I give them the pop that they're looking for? Or is that a passive intervention that they have attached onto as the thing that gives them benefit? And so that's where the situation is a little bit more difficult to navigate, because like, yeah, if they report like, oh, if you pop my back, it's going to feel better. Like, that's one of the things in the research is like, if you don't pop their back, what are you doing? But at the same time, you don't want to feed into this passive intervention mechanism that they may be relying on. And so that's a lot of education has to go along with that usually.
I think ultimately, like in those situations, in most situations, whether it be chronic, acute, exercise is going to win out in the long term if you're just comparing the two. But is that short-term thing that is key. And then framing what you're doing in those scenarios is key. So in that situation, I would typically say, great, I want you to feel better. I can go ahead and do that. But you doing that over and over again, it still brought you here. So now what? Like, what are we going to do next? I love that it helps give relief. That's great. And if we continue to do that same thing, we're going to repeat this pattern, or we can get to the point where you're feeling so much better and you can fire me and then manage it even better on your own.
Yeah, I love those points. We want to, as you said, we know exercise is really bread and butter for us, and we do not want to neglect that. We love the component of creating autonomy of your care. I think that's a big piece to it. And the reality being that, as we said, putting your hands on a patient, listening to their beliefs, these things all factor into being able to get to that point. And if you can't get to that point, if they don't trust you, then I'm not going to be able to get you to doing the right exercises to be able to manage your care as well too. So the way those tie in, I think, is really helpful. Very cool. All right. Well, as always, great stuff, guys. Appreciate the conversation. Looking forward to more next week.